put a little slideshow together. I know this is all about education, and nurse practitioners love education, so I'm going to try to do some educating about what substance abuse is and some of the things that we're doing on the medical side of things to, I won't say fix it, but it's treat it, I guess is a better way of putting it. Do some statistics out. I know we've already had some, but these are just some things that I find interesting. In 2015, there were about 3 million people with an opiate abuse problem. You know, that's a lot, considering there's just over 350 people in this country. We've already thrown out some of the numbers about the prescriptions in Alabama and about the overdoses. In this country, somebody dies of an opiate overdose every 18 minutes. That's 3 an hour. That's a lot of dead people in opiates. Looking at some studies, and this is talking about inpatient treatment. Relapse rates are as high as 90%, as high as 60% the first week out of treatment. It is really tough for these people to stay sober. You know, it's very addicting substances, the opiates. It's sometimes it feels like an uphill battle, and 20% of all suicides have opioids involved, right? I think with substance abuse in general, about half the suicides between alcohol, opiates, and other substances are involved, about 50% of suicides. So it's a big problem. So I want to start by talking about what addiction is, right? A couple of definitions here. The American Medical Association definition: addiction is a primary chronic disease of genetic, psychosocial, and environmental factors influencing its development and manifestations. It's concise. It's not sexy, but it's concise. You know, I prefer the definition from the American Society of Addiction Medicine. You know, addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry, which it is. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. And I know the police have seen some of those other behaviors. It's pretty interesting. I've seen some of those myself. So we'd like to talk a little bit about what's going on with the brain when it comes to substance abuse. You know, the ASAM definition talks about the reward circuitry in the brain. We're talking about the mesolimbic system here. I'm not good with a pointer. Which one's the pointer? What is this right here? This part of your brain and the prefrontal cortex. These are the primary players in substance abuse. This is the system for reward, mood, you know, goal-oriented behaviors. And all of these are involved. Dopamine is the neurotransmitter that's driving the bus on this. Good way I try to explain it to my patients, you know, the feeling you get from a job well done when you've worked hard to accomplish something. You know, the feeling you get when you're hungry to eat a good meal, the feeling that you get when you fall in love, you know, those kinds of things. That's the reward system in your brain that's responsible. Drugs, particularly opiates, stimulate that part of your brain about 10 times more powerfully than any of that stuff. You know, that's why you see people use, and it doesn't matter what they lose. You know, and it's you know, drug has. It's not that they don't love you. It's very businesslike. You know, my brain says I got to get high. I got to get high. I'll go around you. I'll go through you. I'll steal from you. It doesn't matter. I got to get high. That's what my brain is telling me to do when I'm a drug addict. It kind of sucks actually, but it is what it is. Over time, with substance abuse, you know, you get some interesting things that start to happen. Tolerance, you know, when people use and use and use, and they get this massive overstimulation of dopamine in these parts of their brain. You know, everybody learned about homeostasis in high school biology. The body always seeks equilibrium. Well, the body tries to balance these things out. You know, so what the body does is it makes less dopamine, it creates less receptors for dopamine. So drug addicts have to use more and more and more and more, trying to achieve the same results, right? Now with opiates in particular, what you get is suppression of the adrenergic system. This is your autonomic system, anxiety, heart rate, blood pressure, these kinds of things. That's where you get all the fun racing heartbeats, the chills, the sweats, the shaking, all the things that are involved with opiate withdrawal, lots of anxiety. You know, opiate withdrawal is not life-threatening, but to a person, those people feel like they're going to die when they're in withdrawals. Right? And because of the systems involved, you know, withdrawal helps fuel that compulsive behavior that people have towards, you know, drug use. So the more they're in withdrawal, the harder they're going to be trying to get high. And that's what prompts a lot of people to do some of the things they do to get drugs. Right? Craving, right? Anything that a person associates with substance use, people, places, things. This is really bad with IV users. IV users will shoot up water or alcohol just to be shooting up because they get just a little bit of a feel from that. Right? That actually happens. That's why we try to make people aware of this kind of thing. If you go back into the same environment after treatment, around the same people doing the same things, those are the people that are going to be getting high in a week. Because all of these things activate that craving for the drug. It's really complex. It's difficult to treat. It's just a little scale that I kind of wanted to use to show how things progress with substance use. Right in the middle, then we have normal. Right, this is you, me. This is anybody. Everything's okay. Everything's normal. When I take an opiate, I go here. Right, euphoria. That's what you get. A massive release of dopamine. I got fat fingers. You get a massive release of dopamine in the brain, all right? Then it wears off and you come back to normal. Use again, euphoria, back to normal. Now over time, what starts happening is we get a little bit less euphoria and we start swinging towards this side of the scale. Now as we lose the ability to have that effect of dopamine in our brain with consistent use, we start to get into a state that we call dysphoria, right? Because dopamine is so heavily involved in mood. When I don't have a lot of it, I'm miserable, right? This is why it plays a role in depression. And these people tend to get depressed, irritable. I don't know how many of you have family members that are drug addicts or alcoholics. If you've ever seen them when they really haven't been high in a while and they really need something in their withdrawal, they're not a lot of fun to be around, right? And over time, what happens is, they start sliding all the way over here. We're having to use to just get back to normal, right? And you'll talk to a lot of drug addicts, that's what you'll hear them talk about. I don't get high anymore. I'm using just to avoid withdrawal at this point. And that's kind of where it gets to over time. And when they start getting in here, this is when we start seeing people get suicidal, right? And it'd be nice if we could keep it from getting that far, but like I said, it's really difficult to do. Drugs are a hell of a lot more powerful than we are, unfortunately. Got a lot of co-occurring mental disorders that go on with substance abuse. Some of the more common: bipolar disorder, major depression, ADHD, personality disorders, psychotic disorders, especially with meth use, right? Trauma, PTSD, working in the office, working inpatient at Radford with people. I think what I probably see the most of is the first one and the last one. A lot of depression. I know there's a kind of a chicken or the egg argument, does the depression lead to the substance abuse? Does substance abuse lead to depression? The answer is yes, right? It goes both ways. So a lot of times I don't really worry about it. We treat them both, and it's ideal to treat them both, because if you don't treat one, you're going to have a lot of difficulty treating the other one. Right? It's just the way that it works, especially with trauma patients. And there's an amazing number of trauma patients. If I had to guess at a figure, I would say 50–75% of the patients that we treat inpatient are people with a history of trauma, physical abuse, sexual abuse, all kinds of things. I got some pretty bad stories I can tell about some of these patients. So as far as treatment, the kind of things that we're doing these days, we got a few different options. The oldest is probably the rapid detox. This is what most of your inpatient facilities are doing. This is what we do over at Bradford. A 5-day, pretty quick taper, a lot of comfort meds for the symptoms. It works. The relapse rates are still kind of high there. There's medication-assisted treatment. Those are the kinds of things we do more at the office. I will get into those in a little more detail in a minute. Psychotherapy, cognitive behavioral therapy, these are things, seeing somebody weekly, bi-weekly at the office. Recognize some counselors in the audience. 12-step recovery, that's my personal favorite because that's how I got clean, all right, and it kind of fits with the ASAM definition. But even that, it's really hard to stay sober. The desire to get high is very, very strong for these people. It's stronger than anything. Like I said, it's 10 times better than the best sex you can imagine. That's how strong it is. I got to put it like that so you can understand. As far as the kind of things that we're doing at the office, medication-assisted treatment with buprenorphine. A lot of people have mixed thoughts about buprenorphine. Honestly, being a guy who got sober, doing the abstinence route, going to AA and things like that, I was against this for the longest time. But as I started working as a nurse and nurse practitioner and seeing some of the results with people in the office, at this point, with the rates that people are dying, that people are ending up in jail, it's about harm reduction, it's about stability, it's about quality of life. And a lot of the people that we have that are doing well on buprenorphine, they have that back, and I would say about 60% of those people are doing really well. There's another 20% who do okay, and then there's about another 20% that's kind of a revolving door. Lots of time there's meth involved in that. A lot of meth use out there lately, and somebody's going to talk about that later on. There's lots of different formulations available of buprenorphine. They have generic forms. Everybody knows Suboxone, at least most people do. There's other ones, Botox, Zopsol. They have just released, I think in March of this year, a monthly injectable, which I think is really ideal because that'll cut way down on diversion, and there is diversion with this stuff, unfortunately. It's hard to catch people.